My name is Tom Hutson. I am the director of the GU Oncology program with Texas Oncology at Baylor Sammons Cancer Center, where I also co-chair the Urologic Cancer Research and Treatment Center. I'm a professor of medicine at Texas A&M College of Medicine, and I run the Early Development Phase 1 program for Sarah Cannon Research Institute. Study 205 was the trial that resulted in the regulatory approval of lenvatinib and everolimus. And in that study, we took patients who had received prior anti-angiogenic therapy as the front line and randomized them to receive one of the lenvatinib everolimus arms. LENVIMA in combination with everolimus is indicated for the treatment of adult patients with advanced RCC following one prior anti-angiogenic therapy. The efficacy was evaluated in a multi-center randomized 1:1:1 study in which 153 patients with advanced or metastatic renal cell carcinoma who have previously received anti-angiogenic therapy received LENVIMA 18 mg orally once daily with everolimus 5 mg orally once daily, LENVIMA 24 mg orally once daily, or everolimus 10 mg orally once daily. Patients were required to have histological confirmation of clear cell RCC and ECOG performance status of 0 or 1. Patients were stratified by hemoglobin level less than or equal or greater than 13 gram per deciliter for males and less than or equal or greater than 11.5 gram per deciliter for females, and corrected serum calcium greater than or equal to 10 mg per deciliter versus less than 10 mg per deciliter. The major efficacy outcome measure was investigator-assessed PFS evaluated according to RECIST 1.1. In Study 205, the median progression-free survival was 14.6 months. There was a 14.6-month median progression-free survival in second line. The 95% confidence interval was 5.9 to 20.1 with LENVIMA plus everolimus versus 5.5 months with a 95% confidence interval of 3.5 to 7.1 with everolimus alone. The hazard ratio was 0.37 and 95% confidence intervals were 0.22 to 0.62. 26 events, or 51%, occurred in the LENVIMA and everolimus arm versus 37 events, or 74%, in the everolimus arm. Death occurred in 5 patients, 10%, who received LENVIMA and everolimus versus 2 patients, 4%, who received everolimus alone. There was a greater than 2-year median overall survival. The overall survival median was 25.5 months, with confidence interval 16.4 to 32.1 months with LENVIMA plus everolimus versus 15.4 months, 95% confidence interval 11.8 to 20.6 months with everolimus alone. The hazard ratio was 0.67 with 95% confidence interval 0.42 to 1.08. At the time of the analysis, 63% of deaths, 32 patients, had occurred in the LENVIMA plus everolimus arm, and 74% of deaths, or 37 patients, had occurred in the everolimus arm. There was a 37% response rate in second line, 35% partial response, and 2% complete response. 95% confidence interval was 24% to 52% with LENVIMA and everolimus versus 6% partial response and 0% complete response with everolimus alone, 95% confidence interval 1% to 17%. Adverse reactions, some of which can be serious or fatal, may occur with LENVIMA, including hypertension, cardiac dysfunction, arterial thromboembolic events, hepatotoxicity, renal failure or impairment, proteinuria, diarrhea, fistula formation and gastrointestinal perforation, QT interval prolongation, hypocalcemia, reversible posterior leukoencephalopathy syndrome, hemorrhagic events, impairment of thyroid-stimulating hormone suppression, thyroid dysfunction, impaired wound healing, osteonecrosis of the jaw, and embryo-fetal toxicity. Based on its mechanism of action and data from animal reproduction studies, LENVIMA can cause fetal harm when administered to a pregnant woman. Females of reproductive potential should be advised to use effective contraception. Based on the severity of the adverse reaction, LENVIMA should be interrupted, reduced, and/or discontinued. As with any medication, it's important to review the adverse reactions in the prescribing information. It is important to note that most patients will need dose modification strategies as guided by the prescribing information to help manage adverse reactions during their treatment journey. Before starting any therapy in a patient, I myself and my office staff spend a lot of time setting expectations and goals for patients. We have discovered that it's much better to spend the time early in the treatment of the patient, getting everyone on board, the patient and the caregivers, as to what the expectations are, what the side effects are, the management strategies for side effects, so that as the treatment unfolds, they are better equipped to handle it. So starting off with therapy, we'll spend a lot of time reviewing the most common side effects that can be experienced. What my experience has been with patients I'm treating when they're starting therapy, a lot of the support systems that are in place for patients. I meet with my patients very regularly during the first few months of starting therapy. As a clinician, you can kind of get an understanding very easily and very quickly with your patient. Are they suffering from more side effects than you would expect 2 weeks into therapy? Or are they really just tolerating things? They're just, nothing's phasing them. And so we can make adjustments and tweak their therapy and use best supportive care. The most common adverse reactions for LENVIMA plus everolimus in study 205 and greater than or equal to 30% include diarrhea and fatigue, hypertension, renal failure, proteinuria, vomiting, hemorrhagic events, nausea, decreased appetite, arthralgia, myalgia, dyspnea, stomatitis or oral inflammation, peripheral edema, cough, abdominal pain, rash, and decreased weight. In patients that have very mild or moderate side effects, often this can be handled by supportive care and in some cases holding therapy until resolution. It's important though, whenever we do consider dose reducing, that we actually let the patient stop therapy, give a break from treatment to allow the side effect to resolve before returning to the dose or lower dose. The prescribing information contains a table that outlines the recommended dose modifications for the different adverse reactions that a patient may experience while taking LENVIMA and everolimus. Depending on the adverse reaction, LENVIMA can be either withheld until the adverse reaction returns to an acceptable level, reduced, or permanently discontinued. For adverse reactions pertaining to LENVIMA in combination with everolimus, withhold or reduce the LENVIMA dose first, and then the everolimus dose for adverse reactions of both LENVIMA and everolimus. Refer to the everolimus prescribing information for additional dose modification information. When we're discussing the particular therapy choice, in this case LENVIMA and everolimus with the patient, we want to make sure that we review what we expect the most common side effects to be in the management strategies. That helps the patient become more at ease knowing what to expect and then what our interventions potentially would be. We want to make sure that they feel very comfortable in reaching out to our staff. And sometimes patients feel that when they reach out, they're bothering you, and we need to overcome that. I found that meeting with my patients on a regular basis for the first few months, every couple of weeks, helps that along, so that we don't put all the burden on the patient to call us, but we actually check in on them during that time. And also I want to share with them what the expectations are, what has happened when patients in my practice have received the drug, and that if they do run into a side effect, for them not to feel that somehow that makes them different. And I share with them that a large portion of patients in the clinical trial did have side effects that required actual dose interruption and dose reduction. And despite doing that, they were able to maintain therapy. I think the biggest issue that some prescribers face with lenvatinib and everolimus stems to the fact that kidney cancer is a rarer tumor, and the average general community oncologist may only see a handful of them a year. And so they don't get the experience of or the nuances of the various therapies. And some of them may be reluctant or scared when they just look at the product labeling of lenvatinib and everolimus in regards to side effects.
Indication: LENVIMA, lenvatinib, is indicated in combination with everolimus for the treatment of adult patients with advanced renal cell carcinoma, RCC, following one prior anti-angiogenic therapy. Important safety information: warnings and precautions. Hypertension. In DTC, differentiated thyroid cancer, hypertension occurred in 73% of patients on LENVIMA. In RCC, renal cell carcinoma, hypertension occurred in 42% of patients on LENVIMA and everolimus. Systolic blood pressure greater than or equal to 160 millimeters of mercury occurred in 29% of patients, and 21% had diastolic blood pressure greater than or equal to 100 millimeters of mercury. In HCC, hepatocellular carcinoma, hypertension occurred in 45% of LENVIMA-treated patients. Grade 4 hypertension was not reported in HCC. Serious complications of poorly controlled hypertension have been reported. Control blood pressure prior to initiation. Monitor blood pressure after 1 week, then every 2 weeks for the first 2 months, and then at least monthly thereafter during treatment. Withhold and resume at reduced dose when hypertension is controlled, or permanently discontinue based on severity. Cardiac dysfunction. Serious and fatal cardiac dysfunction can occur with LENVIMA. Across clinical trials in 799 patients with DTC, RCC, and HCC, grade 3 or higher cardiac dysfunction occurred in 3% of LENVIMA-treated patients. Monitor for clinical symptoms or signs of cardiac dysfunction. Withhold and resume at reduced dose upon recovery or permanently discontinue based on severity. Arterial thromboembolic events. Among patients receiving LENVIMA or LENVIMA plus everolimus, arterial thromboembolic events of any severity occurred in 2% of patients in RCC and HCC and 5% in DTC. Grade 3 through 5 arterial thromboembolic events ranged from 2% to 3% across all clinical trials. Among patients receiving LENVIMA with pembrolizumab, arterial thrombotic events of any severity occurred in 5% of patients in CLEAR, including myocardial infarction 3.4% and cerebrovascular accident 2.3%. Permanently discontinue following an arterial thrombotic event. The safety of resuming after an arterial thromboembolic event has not been established, and LENVIMA has not been studied in patients who have had an arterial thromboembolic event within the previous 6 months. Hepatotoxicity. Across clinical studies enrolling 1,327 LENVIMA-treated patients with malignancies other than HCC, serious hepatic adverse reactions occurred in 1.4% of patients. Fatal events, including hepatic failure, acute hepatitis, and hepatorenal syndrome, occurred in 0.5% of patients. In HCC, hepatic encephalopathy occurred in 8% of LENVIMA-treated patients. Grade 3 through 5 hepatic failure occurred in 3% of LENVIMA-treated patients. 2% of patients discontinued LENVIMA due to hepatic encephalopathy, and 1% discontinued due to hepatic failure. Monitor liver function prior to initiation, then every 2 weeks for the first 2 months, and at least monthly thereafter during treatment. Monitor patients with HCC closely for signs of hepatic failure, including hepatic encephalopathy. Withhold and resume at reduced dose upon recovery or permanently discontinue based on severity. Renal failure or impairment. Serious, including fatal renal failure or impairment, can occur with LENVIMA. Renal impairment was reported in 14% and 7% of LENVIMA-treated patients in DTC and HCC, respectively. Grade 3 through 5 renal failure or impairment occurred in 3% of patients with DTC and 2% of patients with HCC, including 1 fatal event in each study. In RCC, renal impairment or renal failure was reported in 18% of LENVIMA plus everolimus-treated patients. Initiate prompt management of diarrhea or dehydration hypovolemia. Withhold and resume at reduced dose upon recovery or permanently discontinue for renal failure or impairment based on severity. Proteinuria. In DTC and HCC, proteinuria was reported in 34% and 26% of LENVIMA-treated patients, respectively. Grade 3 proteinuria occurred in 11% and 6% in DTC and HCC, respectively. In RCC, proteinuria occurred in 31% of patients receiving LENVIMA plus everolimus. Monitor for proteinuria prior to initiation and periodically during treatment. If urine dipstick proteinuria greater than or equal to 2+ is detected, obtain a 24-hour urine protein. Withhold and resume at reduced dose upon recovery or permanently discontinue based on severity. Diarrhea. Of the 737 LENVIMA-treated patients in DTC and HCC, diarrhea occurred in 49%. In RCC, diarrhea occurred in 81% of LENVIMA and everolimus-treated patients. Diarrhea was the most frequent cause of dose interruption reduction, and diarrhea recurred despite dose reduction. Promptly initiate management of diarrhea. Withhold and resume at reduced dose upon recovery or permanently discontinue based on severity. Fistula formation and gastrointestinal perforation. Of the 799 patients treated with LENVIMA or LENVIMA plus everolimus in DTC, RCC, and HCC, fistula or gastrointestinal perforation occurred in 2%. Permanently discontinue in patients who develop gastrointestinal perforation of any severity or grade 3 through 4 fistula. QT interval prolongation. In DTC, QT/QTC interval prolongation occurred in 9% of LENVIMA-treated patients, and QT interval prolongation of greater than 500 milliseconds occurred in 2%. In RCC, QTC interval increases of greater than 60 milliseconds occurred in 11% of patients receiving LENVIMA plus everolimus, and QTC interval greater than 500 milliseconds occurred in 6%. In HCC, QTC interval increases of greater than 60 milliseconds occurred in 8% of LENVIMA-treated patients, and QTC interval greater than 500 milliseconds occurred in 2%. Monitor and correct electrolyte abnormalities at baseline and periodically during treatment. Monitor electrocardiograms in patients with congenital long QT syndrome, congestive heart failure, bradyarrhythmias, or those who are taking drugs known to prolong the QT interval, including Class 1A and 3 antiarrhythmics. Withhold and resume at reduced dose upon recovery based on severity. Hypocalcemia. In DTC, grade 3 through 4 hypocalcemia occurred in 9% of LENVIMA-treated patients. In 65% of cases, hypocalcemia improved or resolved following calcium supplementation with or without dose interruption or dose reduction. In RCC, grade 3 through 4 hypocalcemia occurred in 6% of LENVIMA and everolimus treated patients. In HCC, grade 3 hypocalcemia occurred in 0.8% of LENVIMA treated patients. Monitor blood calcium levels at least monthly and replace calcium as necessary during treatment. Withhold and resume at reduced dose upon recovery or permanently discontinued depending on severity. Reversible posterior leukoencephalopathy syndrome, RPLS. Across clinical studies of 1,823 patients who received LENVIMA as a single agent, RPLS occurred in 0.3%. Confirmed diagnosis of RPLS with MRI. Withhold and resume at reduced dose upon recovery or permanently discontinue depending on severity and persistence of neurologic symptoms. Hemorrhagic events. Serious, including fatal hemorrhagic events can occur with LENVIMA. In DTC, RCC, and HCC clinical trials, hemorrhagic events of any grade occurred in 29% of the 799 patients treated with LENVIMA as a single agent or in combination with everolimus. The most frequently reported hemorrhagic events were epistaxis and hematuria. In DTC, grade 3 through 5 hemorrhage occurred in 2% of LENVIMA-treated patients, including one fatal intracranial hemorrhage among 16 patients who received LENVIMA and had CNS metastases at baseline. In RCC, grade 3 through 5 hemorrhage occurred in 8% of LENVIMA plus everolimus-treated patients, including one fatal cerebral hemorrhage. In HCC, grade 3 through 5 hemorrhage occurred in 5% of LENVIMA-treated patients, including 7 fatal hemorrhagic events. Serious tumor-related bleeds, including fatal hemorrhagic events, occurred in LENVIMA-treated patients in clinical trials and in the post-marketing setting. In post-marketing surveillance, serious and fatal carotid artery hemorrhages were seen more frequently in patients with anaplastic thyroid carcinoma, ATC, than other tumors. Safety and effectiveness of LENVIMA in patients with ATC have not been demonstrated in clinical trials. Consider the risk of severe or fatal hemorrhage associated with tumor invasion or infiltration of major blood vessels, example, carotid artery. Withhold and resume at reduced dose upon recovery or permanently discontinue based on severity. Impairment of thyroid-stimulating hormone suppression, thyroid dysfunction. LENVIMA impairs exogenous thyroid suppression. In DTC, 88% of patients had baseline thyroid-stimulating hormone, TSH level, less than or equal to 0.5 milliunits per liter. In patients with normal TSH at baseline, elevation of TSH level greater than 0.5 milliunits per liter was observed post-baseline in 57% of LENVIMA-treated patients. In RCC and HCC, grade 1 or 2 hypothyroidism occurred in 24% of LENVIMA plus everolimus-treated patients and 21% of LENVIMA-treated patients, respectively. In patients with normal or low TSH at baseline, elevation of TSH was observed post-baseline in 70% of LENVIMA-treated patients in HCC and 60% of LENVIMA and everolimus-treated patients in RCC. Monitor thyroid function prior to initiation and at least monthly during treatment. Treat hypothyroidism according to standard medical practice. Impaired wound healing. Impaired wound healing has been reported in patients who received LENVIMA. Withhold LENVIMA for at least 1 week prior to elective surgery. Do not administer for at least 2 weeks following major surgery and until adequate wound healing. The safety of resumption of LENVIMA after resolution of wound healing complications has not been established. Osteonecrosis of the jaw, ONJ. ONJ has been reported in patients receiving LENVIMA. Concomitant exposure to other risk factors such as biphosphonates, denosumab, dental disease, or invasive dental procedures may increase the risk of ONJ. Perform an oral examination prior to treatment with LENVIMA and periodically during LENVIMA treatment. Advise patients regarding good oral hygiene practices and to consider having preventative dentistry performed prior to treatment with LENVIMA and throughout treatment with LENVIMA. Avoid invasive dental procedures if possible while on LENVIMA treatment, particularly in patients at higher risk. Withhold LENVIMA for at least 1 week prior to scheduled dental surgery or invasive dental procedures if possible. For patients requiring invasive dental procedures, discontinuation of biphosphonate treatment may reduce the risk of ONJ. Withhold LENVIMA if ONJ develops and restart based on clinical judgment of adequate resolution. Embryo-fetal toxicity. Based on its mechanism of action and data from animal reproduction studies, LENVIMA can cause fetal harm when administered to pregnant women. In animal reproduction studies, oral administration of lenvatinib during organogenesis at doses below the recommended clinical doses resulted in embryo-toxicity, fetotoxicity, and teratogenicity in rats and rabbits. Advise pregnant women of the potential risk to a fetus and advise females of reproductive potential to use effective contraception during treatment with LENVIMA and for 30 days after the last dose. Adverse reactions. In RCC, the most common adverse reactions observed in LENVIMA and everolimus-treated patients were diarrhea, fatigue, arthralgia, myalgia, decreased appetite, vomiting, nausea, stomatitis, hypertension, peripheral edema, cough, abdominal pain, dyspnea, rash, decreased weight, hemorrhagic events, and proteinuria. The most common serious adverse reactions were renal failure, dehydration, anemia, thrombocytopenia, diarrhea, vomiting, and dyspnea. Adverse reactions led to dose reductions or interruption in 89% of patients. The most common adverse reactions resulting in dose reductions were diarrhea, fatigue, thrombocytopenia, vomiting, nausea, and proteinuria. Treatment discontinuation due to an adverse reaction occurred in 29% of patients. Use in specific populations. Because of the potential for serious adverse reactions in breastfed children, advise women to discontinue breastfeeding during treatment and for 1 week after the last dose. LENVIMA may impair fertility in males and females of reproductive potential. No dose adjustment is recommended for patients with mild or moderate renal impairment. LENVIMA concentrations may increase in patients with DTC, RCC, or EC, endometrial carcinoma, and severe renal impairment. Reduce the dose for patients with DTC, RCC, or EC and severe renal impairment. There is no recommended dose for patients with HCC and severe renal impairment. LENVIMA has not been studied in patients with end-stage renal disease. No dose adjustment is recommended for patients with HCC and mild hepatic impairment, child Pug A. There is no recommended dose for patients with HCC with moderate child Pug B or severe child Pug C, hepatic impairment. No dose adjustment is recommended for patients with DTC, RCC, or EC and mild or moderate hepatic impairment. LENVIMA concentrations may increase in patients with DTC, RCC, or EC and severe hepatic impairment. Reduce the dose for patients with DTC, RCC, or EC and severe hepatic impairment. For more information about LENVIMA, please see available full prescribing information.